Hello guys, so today we're going to be continuing our discussion on the Family Medicine Clinical Mastery Series Form 2. And in the previous video on the Family Medicine discussion, we actually discussed only three questions from the second form, the first three questions only. And the reason for that was that because concepts in family medicine are a bit difficult to explain, and because they're sort of all over the place, they're associated with so many different subjects at the same time. It takes quite some time to explain the whole concept completely. So today we're just going to continue from there, and we'll see how many questions we get done in this session. So we have our question 4 that says that a healthy 14-year-old girl is seen for a routine well child visit. She reports being sexually active with her boyfriend for 6 months and says that they use condoms consistently. She also takes an oral contraceptive pill. She smokes about one pack of cigarettes weekly and drinks alcohol occasionally at weekend gatherings. The physical examination is unremarkable. Which of the following is the most appropriate next step in management? So these are the different options, and I'll let you do the question by yourself, and then we'll discuss it. So basically, on the first look, this question is not really asking for you for any diagnosis or any clinical evaluation. This is a sort of a ethics kind of a question, in which there are different kind of options given that really test you on how to explore the patient more in an ethical scenario or a discussion based scenario more than it being actually a clinical scenario. So let's get on to it. The concept basically is that it is something known as motivational interviewing for health behavior change in adolescents. So what you're doing basically is you are interviewing the patient, but the tone, sort of the backdrop of the interview, is in a motivational tone. It is in a tone which encourages the patient to come out. That is why it is known as motivational interviewing. So the correct answer would be to inquire about her attitudes towards smoking and health. Now, if you see the other options as well, explain the long-term health risks of the smoking, schedule a meeting with the parents to discuss smoking, prescribe a nicotine patch, and like looking at all of these options and then looking at the correct one, which is explore her attitudes towards smoking and health. So just by this difference, you must now have some sort of an idea that what we are hinting towards. But let's discuss it in a bit of more detail. So the reasoning that is present here is that you have to guide, and you don't have to dictate. Just guide, don't dictate, because adolescents are developing autonomy and identity. So you don't sort of want to just go in there and start dictating to the patient on what to do or to criticize the patient on what to do, because you must understand that confrontation or lecturing often triggers resistance. So the patient right in front of you is an adolescent, and adolescents are creating an identity for themselves. So they are already getting quite a lot of confrontation, maybe from their home, maybe from their school where they're studying, or maybe they're getting some confrontation from the friends group. So you don't want to be one of those kinds of bodies. You want to be a safe place for the patient. So you have to avoid confronting or lecturing the patient. Then again, because if the patient feels attacked, then the patient would not open up to you. So our goal here is to help the patient recognize ambivalence, to explore personal motivations and self-initiate change. So the first step would be to always ask open-ended and reflective questions, like to know how the patient feels about a certain habit or a certain act that they have committed, You have to first ask about that. What do you enjoy about it? Why don't you like it? Or what don't you like? Or how do you feel about it? How does it affect your personality? Because our expectation at that point is to first understand what the patient thinks about the habit. Maybe the problem is on a very cursory level, and you don't really need big interventions, or you don't need to prescribe a nicotine patch if the patient is just trying out or just smoking occasionally in parties or in places where the patient's friends are present to just get socially accepted. So you have to understand that in that sort of scenario, our plan towards that patient would be a bit different rather than somebody who has a full-fledged addiction of the smoking. Then our management towards that patient would be different. So we first have to understand what the patient feels and which place the patient is coming from. So what not to do. The incorrect approach is obviously you don't have to lecture or warn about the health risks. So mostly what people think they should do is scare the patient into, they think scaring the patient into quitting the habit is the right approach. Like, for example, if somebody is having any sexual activity, or if someone is having an addiction of smoking or drugs, then what some students believe is to scare the patient into thinking that it is a very bad habit and you are going to die unless you leave that. And that is a bad approach because on paper, however justified it might seem to scare someone to leave a habit, it's not really the right approach. In real life, it rarely translates into any good outcome. Right? You cannot really scare somebody in real life to leave a habit. That's not really how it works, because if the patient is mostly in bad habits, patients don't really see any bad outcome immediately, so they will not take that tactic as very serious. I mean, even if they do get scared, they probably get paranoid also, which would psychologically harm the patient more than the benefit that you're trying to do. So you must understand that whatever looks good in your mind or on paper doesn't really translate to real life. And even if it really looks good into real life, it doesn't really translate into something that is correct in the USMLE exam. So you must understand that. So lecturing and warning is not a good step, because it would create a judgmental scenario, and it would really make some resistance between you and the patient. So you have to avoid this. Telling her to quit immediately, because that really ignores the readiness stage. So for long lasting impact, you must understand that that change must come from the patient herself or himself. Telling the patient to quit or to change or dictating them what to do might result in a short term change, but not a long term effect. So there's no really need to do that. Prescribing nicotine replacement and bupropion right away. So again, this is pharmacological therapy, and we don't really know that if the patient is really an addict, right? She's just started this topic of smoking, and we don't really know how long it has been since the patient has started smoking. So we're not ready for that. And also, prescribing whenever they would want you to go towards the pharmacological option, they would make it quite clear. They would make it quite clear that they are asking about the pharmacologic aspect, right? So you don't really need to worry about that. And informing parents is absolutely wrong, because then it violates the confidentiality. And you are allowed to violate the confidentiality in some cases. Those cases we will discuss later on, but not in these kind of cases, especially not something about, say, sexuality or addictive behaviors. You're not supposed to violate confidentiality. That would be a crime. And scheduling a family meeting, again, This undermines the trust of the adolescent. Now, there's a motivational interviewing framework that you must understand. And this framework is something that it's not much for you to memorize, but students often do memorize through this mnemonic of OARS, OARS, and every word, every initial alphabet stands for its own meaning. So the O in the OARS stands for open-ended questions. So technique is to basically encourage the patient to express feelings and encourage them to talk, basically. Encourage them to start a discussion about what they're doing and like what do they feel about doing, right? And why do they think they're doing this? So these kind of open-ended questions is the first step of the OARS mechanism. The next is of affirmations. So in everything that is being discussed, you have to appreciate the strength and you have to really reinforce self-confidence in the patient. Because if the patient is going to fall into guilt and self-doubt, then what we mean to achieve would not get achieved, right? We mean to achieve long-lasting impact and change in the patient. That cannot be done if the patient is in self-doubt. Right? So you need to say things like you've already shown responsibility by using contraception. So you need to appreciate the patient for the strength that they have shown. Then from R, it comes reflective listening, the next part of ORS, which means that you have to mirror back the patient's emotions. You're saying smoking helps you relax when stressed. So this is something the patient might say, and you're not supposed to mirror back the emotion. So you're not basically saying that you're right. It must be true. You're just mirroring back what the patient is saying, so that the patient could get the feel that you're listening to what they're saying, and maybe you're sort of feeling what they're feeling. Right? If the patient feels that you're not showing any kind of empathy, the patient would just close down, and that person would not confide in you. And the last part is summarizing. So you want to highlight what is important. Um, so even if the patient says many things, you have to summarize the discussion to the important point. So it could be like, so you like that it calms you, but you don't like how your parents would react. So you have to focus on the problem, right? Obviously, the patient would say positive things about a habit, maybe negative things about a habit, maybe both. But our goal is to enact real long lasting change in the patient. So, no matter what the patient says positively, we have to make it sound like that is the problem that needs to be changed, right? Uh, Falling onto these principles, not as a lecture. You must make sure that it doesn't sound like a lecture. Okay, so this is a mechanism that you can follow. Mostly what happens is that they give you a question that is already on one of these points. So maybe in the question you have already asked open-ended questions or you have affirmed the behaviors, and they just ask what should you say next. So what students do is memorize this mnemonic and then identify where the question is currently, and then obviously then figure out what to say next according to the mnemonic. So stages of change model, which is a trans-theoretical model. Now this is a model for change. Now this was a model for motivational interviewing, which sort of gives you what to say. This is a change model, which means that it basically helps you identify where the patient is. Right, so you can use both of them. But the concept behind this is that looking at the description or what they are giving you, the clues in the question, you can identify what stage that they are in, and in what stage do you then have to uh, reinforce or to transition them into. So whether the patient is in the no pre-contemplation stage in which the patient is not considering change, then you have to raise their awareness gently. If something is wrong, you have to tell that patient. Maybe the patient is not aware of the bad effects. Then there is the contemplation stage in which the patient acknowledges the issue but is still undecided. Then you have to explore the ambivalence of the patient. Then you just have to say that what do you like and dislike about it, so that we could know that whether the patient likes it more, dislikes it more, and so we could move forward with with that idea. Then there is the preparation phase in which the patient would intend to act soon. It shows the intention. The patient shows the intention, but then again, you have to help set goals because the patient doesn't know where to start from. Then there is the action phase in which the patient is making changes. Maybe he's stayed away from cigarettes or drinking for quite some time now. So that's what you have to make sure that you have to provide support and provide appreciation and just make sure that the patient stays on that pathway. Then there is a maintenance phase in which there is sustained behavioral change. The patient has now stayed away from any bad addiction or bad behavior since quite some time. Your only role right now is to prevent relapse. Now, most of these, such as I would just go out and say that, like the top four, are mostly dialogue options, mostly comprised of dialogues. But the fifth option of preventing relapse, now this could entail some things that the physician might do. The physician might give the number of a support group to the patient. The physician might discuss an analogy with the patient to appreciate him. So this is more than dialogue. So you must understand. But once you go through UWorld and any QBank, you will get exposure to different kinds of this kind of questions. So you would know what I'm talking about. So this stage of this change model, you have to know this is important. Our patient is in the contemplation stage. So the patient physician is required to explore the ambulance and not push immediately. So first of all, you know what to say, and then you know when to say it. So this stage, if you identify which stage she's in, then you would know also that what you're choosing is the right answer. So you must know both of these, right? So these are differentials. How do you approach risky adolescent behaviors? So let's say, for example, there is sexual activity. So your approach should be to screen for STIs and discuss contraception. And you need to maintain confidentiality unless any abuse or coercion has occurred. Substance use, for smoking and alcohol, we have discussed you have to use the emotional intervene tactic. You have to avoid parental disclosure again to avoid any sort of mistrust or miscommunication. But if any person's safety is concerned, then of course you must avoid the confidentiality. If there is depression, suicidality, and abuse, then you must assess it privately and directly. You must directly ask for depression, suicidality, and abuse, and then assess it based on the response. So you have to report it if life or safety is at risk, either someone else's or either the patient's. And if there is a poor academic performance, then you must explore the psychosocial context of it. So head assessment is an assessment in which it explores the psychosocial component. So the patient is maybe getting bullied, maybe getting ridiculed in the workplace, in the place of study, then you must explore all of these options. So this is how you're supposed to approach risky behaviors in adolescents. Moving forward, this is the heads assessment, which we discussed earlier, and this is sort of a snapshot to discuss psychosocial screening in adolescents for depression or for any sort of a bullying or fear. So you're not supposed to remember this, but it's just there for you to see. And this is always performed in private without the parents being present to foster trust among you and the patient. All right, so confidentiality, it's a bit of a snapshot in that topic. Confidentiality in its own is a very vast topic comprising of different branches and different sub branches. But just a summary is that sexual activity, consensual, same age, is confidential information and it does not require any mandatory reporting. And same goes for substance abuse, unless the patient is in danger and like imminent danger, then only. But mostly, as far as the exam is concerned, I have not seen it a reason to report substance abuse. I haven't seen it as a reason to report just yet. Abuse, assault, and suicidal ideation are not confidential, and you have to mandatory report it. because it is causing harm to oneself or to someone else. So you have to report it, right? And even if a suicidal patient asks you that if you're going to tell this to someone, you are required to tell the patient that yes, you can or you will violate the confidentiality if the information proves that someone is in danger. Even if yourself you are in danger, I have to report it. And that is what you have to say. You can't tell the patient that no, you won't report it because that is going to be a lie. And you're not really allowed to lie to patients. And STI pregnancy testing is a confidential information, but what is important, it does not require reporting. So you can treat the patient for STIs and for pregnancy without reporting. And this is really important. All four of these are very important. Side note, to never disclose smoking or sexual activity to parents without the patient's consent unless it poses a safety risk. So the next step logic is mostly if you are given a scenario of where the teen is smoking and not ready to quit. The wrong approach would be to lecture and prescribe patch. The correct approach would be to ask about feelings towards smoking, which leads to a further discussion. An adult smoker which is motivated to quit, you don't just discuss risks, but you also offer the nicotine or the pharmacological management to handle the withdrawals because he's an adult and he's completely decided what he wants to do. The teen substance abuse, the wrong approach would be to call the parents. The correct approach would be to privately discuss the habit of using the heads criteria or the heads assessment. If there's a suicidal teen, you're not supposed to keep it private. You're supposed to report immediately, as I've said. If you are harming yourself or anyone else, I am mandated to report you. So that's question number four. Question number five says a 52-year-old woman presents because she's worried about her risk for thyroid cancer after her father was diagnosed with papillary thyroid carcinoma. She feels well and takes no medications. Physical examination shows no thyroid nodules or abnormalities. Which of the following is the most appropriate screening approach for this patient? And I'll let you solve this on your own. All right, so hopefully you've now had an idea of the answer. The concept is that screening recommendations for thyroid cancer in asymptomatic individuals. The correct answer is palpation of the thyroid gland only, because most thyroid cancers are sporadic. Family history of papillary thyroid carcinoma alone does not increase screening indication. The screening approach is routine palpable to the thyroid, palpation of the thyroid during regular physical exams. So there is no imaging or lab screening in asymptomatic patients. So you can see that the patient is asymptomatic, right? So physical examination shows no thyroid nodules or abnormalities. So even though physical examination has been done, but the most appropriate screening approach, as far as thyroid is concerned, or any organ for that matter, the most appropriate screening for that is examination. Really, well, that's it. Like, there's nothing you can do more, even if there is a family history. So there's a small table that I have created. So when to screen and when not to. Population being if there's a general asymptomatic population, then you're not supposed to screen. The rationale behind it is that thyroid nodules are common, mostly benign, and screening causes overdiagnosis. So you may find thyroid nodules normally, so you're not supposed to just go there and get a screening done. Family history of papillary thyroid carcinoma really requires no screening. It's very high yield to know that even though a carcinoma requires no screening, because the familial risk is minimal. You have to know this, and there is no proven benefit of earlier detection. So there's no really any benefit for screening this. The high risk meant to A to B red mutation carriers prior radiation exposure. Yes, you're supposed to screen in these patients, but still a targeted screening because the they have a genetic mutation and a history for that, not genetic mutation for a syndrome, which is the MEN2A 2B syndrome with the red mutation. It carries medullary carcinoma, and medullary carcinoma has a very high penetrance. So in this situation, that you are supposed to screen for the cancer and the progression of the disease. So these are high yield facts on the thyroid cancer types. You can see most important is papillary thyroid cancer, and it's due to the ionizing radiation. It has some bodies and often any nuclear lymphatic spread. Not really important to know the picture. It has excellent prognosis. Follicular carcinoma is from iodine deficiency, and it's from metagenous spread. Again, from thyroglobulin. The need for survival removal for diagnosis. Need surgical removal for diagnosis, or else you cannot diagnose follicular carcinoma. Medullary carcinoma is found in men 2A 2B syndromes, which is a calcitonin producing tumor from parafollicular C cells. The tumor markers that you're supposed to look at is calcitonin and CEA, because calcitonin is increased in the medullary thyroid carcinoma. Then you have to screen the family for TRET mutation. And finally, there is anaplastic carcinoma, which happens in the elderly or long-standing goiter patients. So it is a rapidly enlarging neck mass and local invasion. So it also has poor prognosis. The algorithm to evaluate the asymptomatic thyroid cancer risk is as follows. So what we'll see is, first we will see the patient, if the patient has family history of thyroid cancer. So we identify what kind of a cancer is given. So if it's papillary or follicular, then really it makes no difference. But if it's a medullary carcinoma that the family has, then we require genetic testing for red mutation. Now you must understand that the family includes first relatives. So if this disease is in second or third relative, it doesn't really count. If the child is exposed to radiation, then of course the baseline ultrasound should may be reasonable. And then you perform the neck palpation during routine visits to palpate a nodule, and to then order a thyroid ultrasound if you see if it fits, or manage for findings, which is for observation. You manage in a benign way, or you do surgery and radioiodine uptake in malignant cases. So why ultrasound screening is not recommended? Because there's a very huge chance of finding an incidental nodule, and most are benign. So we don't really want to overdiagnose disease or find out benign cysts that could lead to unnecessary headache for the patient and for you, and doesn't really, it's not really good for anybody. So it avoids over diagnosis, it avoids unnecessary FNAs, and it also avoids any surgical complications. So ultrasound is diagnostic, not screening. If you remember this sentence, surely you would remember the step that we would do. Right, so thyroid nodule evaluation, if you find a mass, what will happen? First, you have to find out TSH level, and then you have to find out the ultrasound of the thyroid. Then you have to do the FNA aspiration if the nodule is on the dangerous side of things, to evaluate it, and then surgery based on the FNA result. So in asymptomatic patients, the only thyroid cancer that justifies screening is medullary carcinoma, that you need to know. Some high risk population for the screening. First of all, the men population is very strong, men 2A 2B population. Therefore, that you need a screening test for serum calcitonin and red genetic testing. Frequencies for family members only. If there is prior neck radiation, then you can do baseline ultrasound. If it is men type 2, multiple, sorry, not men, this is multiple endocrine neoplasia, Type 2, then of course you go for genetic counseling or thyroidectomy, right? Uh, Family screening in men syndromes, again, this is something that I have written. You must know that 2A and 2B are affected by the red gene. So you might read it at your time, but this is everything that we've discussed so far. And this is it. We'll continue from the next slide.